Professor Ashraf.
Okay, hello everybody. I'd like to welcome you on behalf of IAVA board in one of the distinguished courses directed by Professor Said Farag, IAVA CaseBox. This is the 8th wave. I would like to welcome the distinguished faculty, Sarah, Dr. Rosenberg, and Hatem, and the distinguished faculty, Hani Ragi, Ayman Abul Majd. I would leave the mic to Said Farag to introduce the agenda. Said, Fadal.
Thank you, Professor Ashraf, for the kind introduction for this wave. As usual, we have the bunch of distinguished faculty, and we today in this wave, the wave 8, we are joined by the Herfield Hospital, UK, London, UK, and we will have two sessions with a bunch of interesting cases. The first session will be discussed by and moderated by Dr. Alex, Dr. Hani Ragi, Dr. Sarah Muharram, and the case presented will be by the Dr. Karim Atta and Dr. Hatem Suleiman from UK. And then we will have the second session, which will be also discussed by the distinguished faculty, Professor Ayman Abul Majd, Professor Heba, Professor Hani Mahmoud, and then we will have the presented cases by Dr. Rim Lemuna and Dr. Vizelius. I hope that the cases presented will be fruitful, will carry a lot of educative messages, and I'm sure that we will enrich our knowledge by the great discussion which will be there by the elegant faculty. I will leave the mic now to Professor Hani to start the first session. Professor Hani.
Thank you very much. It gives me a great pleasure to be here with Dr. Alex Rosenberg and Dr. Sarah Muharram Al-Gamal. The first case is by Dr. Karim Atta. It's intractable pulmonary edema and decompensated severe aortic stenosis when kidneys draw away. It's just to let everybody know, these are night sessions in the holy month of Ramadan. So those who are fasting, my colleagues here, should have really been having what's like a siesta now, but they've decided to go for science. And I really appreciate that. It's an unusual time of the day in any other country, but in Ramadan in Egypt, nighttime is a very lively time. So anyway, without more explanation, Dr. Karim Atta al-Basha, Fellowship of Interventional Cardiology from Seckberger Clinic in Germany, and the intractable pulmonary edema with severe AS and where the kidneys draw away. Dr. Karim.
Thank you, Dr. Hani. Thank you, Professor Dr. Said Farag and Dr. Ashraf for this kind invitation. And thank you for panelists, Dr. Sarah Muharram and Dr. Alex. It's a pleasure to me today to present this interesting case, and I hope to be so. It's intractable pulmonary edema in an old female patient with decompensated severe aortic stenosis when kidneys draw away. Our patient is an old female, an 82-year-old, known to be hypertensive and dyslipidemic with type 2 diabetes on oral hypoglycemic drugs. She presented to us in the emergency department for the first time with progressive dyspnea NIHA 3 for 2 weeks duration. On clinical examination, patient had mild grade fever, chest revealed bilateral basal crackles, and on heart auscultation, there was an ejection harsh systolic murmur over the base. The lab showed only evidence of nitrite positive urinary tract infection with normal kidney function. After ECG and echocardiography revealed a heavily calcific aortic valve with peak and mean pressure gradient 84 and 53 millimeter mercury with estimated aortic valve area 0.6 centimeter square with normal ejection fraction and no resting regional wall motion abnormality. So the patient simply was diagnosed as de novo heart failure due to presence of degenerative severe calcific aortic valve stenosis that precipitated by urinary tract infection. The management plan after heart team discussion and calculation of the operation risk, we decided to first to manage the urinary tract infection with antibiotics. then performing transcatheter aortic valve implantation. For workup before TAVI, we decided to perform a CT, TAVI protocol, CT aortography, and coronary angiography. This is the angiogram for this patient that shows proximal RCA, concentric long lesion, while the left system was nearly normal without significant lesions. CT, as we can see, it has a poor quality because the patients cannot hold the breath for a long time, but we can calculate the perimeter for the aortic annulus. And it showed also a severe calcific aortic valve here. But the patient has a low coronary ostium. The RCA height from the annulus was 8 millimeter, and the left coronary artery was only 9 millimeter with narrow sinuses of Valsalva. But the first stop patient developed, unfortunately, a contrast-induced acute kidney injury. The creat increased from 0.85, reaching 4.2, then developed oliguria, congestion, worsening of heart failure symptoms. We decided to postpone TAVI, then cautiously fluid given and diuretics. The creat was improved again after 3 days to 0.82 again. Then we decided to give a time for kidney and postpone the TAVI for 1 month. But again, unfortunately, the patient presented before the planned appointment, about 2 weeks before the appointment, with congestion and symptoms of heart failure again. This is a chest X-ray on presentation, can show the congestion, then worsened to develop bilateral pleural effusion. On diuretics, patient didn't improve, but developed acute cardiorenal syndrome, kidneys shut down, creatinine reached 5.2, patient developed oliguria, then transferred to intensive care unit. Fluorocentesis was performed of 2.5 liters of serous fluid that was transsudate in nature. Cultures were negative, and then hemodialysis started. So we have a complex patient now. She had an acute cardiorenal syndrome. We couldn't give diuretics. Hemodialysis didn't improve the patient. Patient has intractable pulmonary edema in intensive care unit. So we decided to interrupt this vicious circle of aortic stenosis, congestion, low cardiac output, oliguria, with performing an fluoroscopic and TE-guided TAVI plus IVUS-guided PCI for the proximal RCA stenosis. First of all, we have implanted a temporary pacemaker, and this is a dialysis Mahuka, and we have electively intubated the patient, and this is the TE probe. Then this is Jotkin right for guiding, was used without contrast, fluoroscopic guided, and then a workhorse wire was developed with a hooking. It's fortunate luck. In the distal RCA. Then IVUS guided, we have used a Volcano device with manual pull back, and we were lucky to have the full film for coronary angiography on the monitor, the right side. So we have an IVUS, and we have a roadmap for or a reference from the diagnostic coronary angiography. We have used here the IVUS probe to sizing the length and the diameter of the stent. We used a stent, drug-eluting stent, 3 millimeter in diameter and 32 in length. Then here the stent is deployed in the proximal RCA. After that, we performed post-dilatation with non-compliant balloon, 3.5, I think 20 balloon. Then confirming the end result in IVUS, the stent was well expanded with no edge dissection. Then for fear of obstruction in the left coronary, left main coronary ostia, We have performed a technique to insert workhorse wire and barking a stent in the left anterior descending artery, because the height of the left coronary artery was only 9 millimeter. So we used this barking technique to perform an wire in LED, then barking stent here in LED, as we can see here. And another view, this stent here, we can see the stent in the mid LED here. And we have chosen or selected the Edward Sapien S3 Ultra 23 valve, balloon expandable valve. We have both here the big tail only fluoroscopic without use of contrast. And here TE was very, very helpful in optimizing the position of distal part of the valve and the proximal part of the valve. Here, here's the proximal and here's distal. This is the TE here before valve inflation. You could see here is this a valve, and here's the balloon of the valve, and the valve covering the aortic sinuses and aortic leaflet. Here during the inflation, here after the inflation, and here confirming the absence of paravalvular aortic regurgitation. But unfortunately, after the valve implantation, after valve implantation, we would like to remove the stent, but the stent was hanging in the struts of the valve. So we decided to inflate the stent or implant the stent in the left main, and we should be sure that the stent was okay in left main. Here was using only 5 millimeter contrast. Again, and this is the end result. Okay, the follow-up post-TAVI, patient was extubated in the catheter labor. Then 3 days later, hemodialysis was interrupted. In the 5th day, patient was transferred from the intensive care to normal room. And 1 week after the procedure, patient was charged to home with serum creatinine of 1.79. Echo before discharge showed the mean gradient of 17 millimeter mercury with minimal paravalvular leakage at 12 o'clock. In this case, I want to emphasize on only 2 clinical points. The first one, the using of TAVI or the use of TAVI in patients with acute or de novo aortic acute heart failure, and the role of imaging in patients with acute kidney injury. Heart failure in patients with severe aortic stenosis is challenging because those patients are very, very sensitive to fluid balance. When we use the diuretics, patients has low cardiac output, and when we give the fluid, patient enter in congestion very, very easily. In this patient, we have a vicious circle of renal hyperfusion, renal impairment with anuria, increasing congestion. So we should interrupt this vicious circle to have a good outcome. In TAVI without contrast, the main challenge or the main technical challenge was to how to optimally position the valve. And here we depended on fluoroscopic guidance and transesophageal echo guidance. This was very, very helpful in those patients because we didn't use any contrast, unlike OCT. Using a preventive stent implantation or barking stent in the LED for fear of coronary artery obstruction in patients at high risk of coronary obstruction was associated with a good mid-term survival as performed by Palmerini et al. In JACC Intervention 2020. And thank you for your attention.
Thank you, Dr. Karim. And I'd like, before Dr. Hani started, I'd like to do a brief introduction for you, Karim. Dr. Hani is a fresh lecturer of cardiology in Zagazig University. He is trained as a fellow in Germany for complex intervention and TAVI. He is one of the rising stars in Zagazig, and I have the honor to present him today and also to be discussed by you. Okay, Dr. Hani.
Thank you very much. It's a very impressive case. I'd actually like to hear the opinion of Sarah Haram and Alex Rosenberg first, and then I will say what I think.
Thank you. It is indeed an excellent. Congratulations, Dr. Karim. It really shows the use of multimodality imaging, whether non-invasive, invasive, in trying to reach the best diagnosis and best approach of the patients. So you've done that really elegantly, and it was quite a challenging case. I do have a question. When you found the patient was really decompensating and she was really unwell, did you consider doing a balloon aortic valvotomy first, and then consider for later phase for the TAVI? What was the team's thought? What was yours and the team's thought for that?
Of course, Dr. Sarah, this is a very, very good option for many patients, and we have performed one of cases. The patient was in cardiogenic shock, and we have performed balloon valvoplasty, and the patient was really improved after that. But in this patient, I think after patient improvement for the first time, and the creatinine was improved after the first contrast-induced acute kidney injury, we have no emergencies for HARI for balloon valvoplasty, and I think for hazards for balloon valvoplasty for aortic regurg, aortic dissection, and so we have to wait until patient improved. But the second time we should intervene. But it's a very, very good option for balloon valvoplasty alone. Yes, you are right.
Thank you. Thank you. It's a really lovely case. Congratulations once again.
Thank you.
Alex, I'll go. First yours. Thank you.
Thanks, Sarah. And Karim, I echo Sarah's words. This is a spectacular piece of work and really thinking outside the box to be able to do so much without using any contrast. And I congratulate you. I have a question as well. I similarly wondered about balloon aortic valvuloplasty. But the other thing I wondered at the beginning of the presentation was what the rationale was for avoiding surgery, given the anatomy, and was aortic valve replacement and CABG considered? And if so, what was the reason that you decided to go for a catheter-directed therapy?
Yes. In our center, we have a heart team discussion every week for 2 times. And this patient was, I think, was not fit for surgery. First, due to age, the patient was old age, 82, and have a single vessel disease, only proximal RCA. So I think here PCI is equal to CABG single vessel disease. Yes, patient was diabetic, yes, but according guidelines, in this old female patient with diabetes and not generally fit for surgery, and as you see, the urologistic 2 score was very high for risk of the operation. So we decided to perform BCI. I know that the BCI was not an emergency for this proximal RCA. This was not very tight, but the RCA ostium was also very low. It was 8 millimeter. So we have decided to use or select the Edward valve. But also we were fear of the coronary artery obstruction due to the heavy calcification in the aortic leaflet. So we decided to perform first PCI using IVUS and then implant the valve. We have published also a very interesting case series about minimal contrast IVUS guided rotational atherectomy BCIs, and it was very, very feasible without complication. So our center had a great experience in this maneuver, IVUS guided BCIs without contrast or with minimal use of contrast.
Great, thanks very much. And then the other question I had, and I don't think any of us know the answer to it, but I'm interested to know what your perspective is how damaging do you think doing this with contrast would have been to her kidneys? Do you think that there's a hope they would have recovered anyway, or do you think that would have sealed the fate and she'd have ended up dialysis dependent had you have used it?
Excuse me again?
So my question is about trying to quantify how damaging potentially the use of contrast is in a patient like this with an established AKI presumed from contrast-induced nephropathy. Are you certain that doing this without contrast was necessary. Do you think it could have been the case that doing it with contrast, actually she would have been okay? What kind of processes did you go through to make this decision to do it using alternate modalities of imaging?
Yes, already the patient was in acute kidney injury for the second time. The second time creatinine reached 5.2 without contrast after about 2 or 3 weeks after improving the creatinine for the first time. So I think we couldn't use any contrast method. Yes.
Fair enough. And congratulations. It's an amazing piece of work.
Thank you so much. Thank you.
Thank you very much, Dr. Karim. Again, like my co-panelists, the end result is what really counts, and you gave us a success. I have a couple of questions. The first one, actually, almost all my questions have been put by both Sarah and Alex Rosenberg now, but my first question is, there must have been an associated factor like dehydration or somebody not stopping metformin in this diabetic patient and taking her to the cath lab on metformin. It's unusual for patients with a creatinine of 0.8 to go to 5 because of diagnostic study. There is something here, and I was wondering what was the nephrology perspective. Because, again, aortic stenosis is not a cause of kidney failure, and certainly kidney failure is not a reversible condition when you do a successful aortic valve replacement. So there is a missing piece here as to why the kidney is deteriorated incredibly and improved, And again, just Alex's last point is, this patient was already on hemodialysis when she went in for the procedure. And that's normally when we're not terribly worried about using contrast. But anyway, it's a great idea that you have the skill and the means of not to use contrast. So my first question is, what was the perspective of nephrology? And I have a second question.
Yes, that's a very, very important notification, and thank you, Dr. Hani, for this. I think there was 2 or 3 points for this precipitation of acute kidney injury. The first point is the patient presented with urinary tract infection, and I think we should first of all do good management of this urinary tract infection before doing the workup for TAVI. The second point, the patient received, I think, not cautious diuretic before performing this 2 studies, CT and coronary angiography, because the patient was first diagnosed as a severe aortic stenosis. So I think the patient received severe diuretics or a huge amount of diuretics. And the third part, routinely, before any diagnostic coronary angiography in our center, we stop the metformin. This is routine. So metformin has no role. But the third point is patient has a long time diabetes, and as you know, the duration of diabetes have a deleterious role on kidney, even with without or with normal creatinine. Patients may have an albuminuria or album creatinine ratio is high, and patient has a good creatinine level. So I think that this not cautious use of diuretics may add a precipitation for this acute kidney injury. And performing two procedure, I think 24-hour or 48-hour interval between coronary angiography and CT, contrast here and contrast again. I think this help for this shutdown of kidneys and this high level of creatinine. The second question regarding hemodialysis. For my knowledge, I think the contrast metal is not completely dialyzable. So hemodialysis has no rule in when giving contrast metal. So we decided to perform that without contrast to avoid permanent dialysis for this old lady.
Thank you. I'm just trying to learn how can I avoid this kind of scenario in a patient who's coming with a normal creatinine in the future, trying to learn from the case. So my second question is, you very eloquently answered as to why you stented the RCA because you think, once you jail it might be difficult to stent in the future. And you showed us also that when you jailed the left main stent, you couldn't pull it out. So this patient ended with a stent in the left main, which she didn't need, and a stent in the RCA, which I think she also didn't need. So my question is, in an older patient with no angina whatsoever, with incidental coronary artery disease, do you PCI them all the time? I mean, I leave those patients. We do the TAVI and we leave them with their coronary artery disease and nothing happens. You know, I was surprised that this RCA was stented, to be honest.
Yes, you are right, Dr. Hani. Yes, it was a point of discussion between our doctors here in Leipzig, but finally we decided to perform a stent. But you are right completely. I agree with you. For me, I couldn't put this stent because when coronary artery obstruction occur after the stent, also it can occur. This is not preventable for the stent. Yes, you are right. I agree, completely agree with you. This stent in RCA. Point of discussion, yes.
Okay, thank you very much.
If you allow me, I'd like to take the chance to have Sarah with us, because these cases, as we saw, as elegantly presented by Karim, it is done guided by the TEE. And I'd like to know if there is any added experience from Sarah how can we use the TEE as an adjuvant imaging tool for implanting TAVI, especially in such a situation.
Thank you, Professor Thisaid. Thank you for the kind question. Well, the role of the TEE here, I mean, the most important thing, especially in patients who have calcified valves, is really for the detection of the paravalvular leakage and to assess, is there any significant paravalvular aortic regurgitation? So that's a very important factor. We have from the CT, we already have good sizing and they good parameters and allows us to assess the annulus sizing as well as the balloon. But I mean, the strength here of the TOE in this situation is the paravalvular leak. I mean, yes, you can with 3D TOE, you can get good size of the annulus as well. But it helps to confirm the CT findings that have been taken in order to assess if is this truly the right size, and as well as with the balloon. So it's multiple decisions, as well as Karim knows very well, and your kind self know very well. But yeah, that's the role of TE situation.
Okay. Karim, do you think that there is any other type of valve which we can avoid with it, this height of coronary? Because, you know, we have a low height for the left and right coronary. I know that you shoot the Edward valve, but I do believe also that a valve like the self-expandable acute new, also because of the 3 crowns, you know, can also do a great job for such a low height for the coronary. What do you think about that?
Yes, Professor said you are right, but this patient, I think we have performed this patient into 2018. Yeah. And accurate new is newly entered the market. Yes. But in literature, there was no difference in coronary obstruction risk between Edward and core valve, for example. The risk is high in this patient because valves were severely calcified and the sinus valsalva was very narrow and the ostia were low. Okay. But you are right. Yeah, accurate new is very, very good option. Yes.
Okay. Dr. Hania, we will leave the mic now for Dr. Alex, Dr. Asara, Dr. Hani to continue the flow of the session. And I think we have one of our distinguished flying birds in UK, my dear friends, Dr. Hatem. It will be kindly, of course, introduced by the panelists, Professor Sarah, Professor Hani, Professor Alex.
Sarah, please.
Thank you. Thank you, Professor Hani. I'd like to introduce my colleague, Dr. Hatem Suleiman. He's a cardiothoracic intensivist consultant and honorary senior lecturer at Harefield and at King's College. He's been recently awarded the EACVI Excellence in Education Awards in his role and for his drive in leading echo imaging in the intensive care and in his great activities as regards for echo education to the in the EACVI as well as the UK and Europe. Thank you, Hatem. The floor is yours.
Thank you very much, Sarah, for the kind introduction. It's a special moment for me, and without any exaggeration, it's a great honor and pleasure to together with you all today. Thank you, Professor Said Farag, for the invitation, for suggesting a joint session with Harefield Hospital. The reason this is a very special moment for me that it has distinguished professors of mine from Egypt, whom I looked at with great respect and admiration, and they were a source of great inspiration for me in my early career. And also it has a distinguished presence from my hospital, Harefield Hospital, with the leaders of our mechanical circulatory support program, my colleague, Dr. Alex Rosenberg and Dr. Vasilis Panoulas. So thank you very much for bringing us together. And in this short presentation, I'm going to discuss with you a case which highlights the role of integrated point-of-care ultrasound in a crashing patient. This is my disclosure. And if you go into PubMed and just write the word point-of-care ultrasound, and I did this about 6 weeks ago, you will see the exponential increase in the number of publications on POCUS around the world. And you can see that we are almost finishing the first quarter of 2022, and the number of publications is almost about to exceed the record number which was achieved in 2021. So this field is exploding literally and booming with lots of publications, which shows the increasing interest and application of point-of-care ultrasound. And this is our case. So a 55-year-old patient, gentleman who was referred to our center a few years ago after complaining of fever, shortness of breath, increasing inflammatory markers. He was warm and sweaty, but his blood investigations were quite concerning. He had increased lactate. It was about 6 on arrival, and his base deficit was -8. He was also hypotensive, which was not responding to IV fluid resuscitation on arrival. And he was also hypoxemic with 15 liters of oxygen via face mask, bringing the arterial sats via the pulse oximeter to only 88%. And his troponin was only mildly raised. And you can see the initial point of care echocardiogram, which was performed, the apical fourth chamber, is showing as an impairment of the left ventricular function. We can only see rocking motion of the LV, but no significant contractility, which was denoting a degree of significant cardiac dysfunction contributing to the current shock state. And those are further views for the point-of-care echocardiographic study. At the same time, parasternal long axis view showing the same significantly reduced left ventricular systolic function with almost preserved right ventricular systolic function visually. And when we went forward and assessed the stroke volume of this patient, the VTI was quite significantly reduced. It was about 4.4 centimeters, which equates to about 14 millimeters stroke volume and cardiac index of only about 0.8 liters per minute per square meter. So by definition, this patient was in a significant state of shock, most likely a state of cardiogenic shock, but we also went forward to assess the right side of the heart, because in this context of acidosis, the RV might be compromised, and we noticed that the RV pulmonary acceleration time was reduced, which denotes an increase in the pulmonary vascular resistance, but without a significant reduction in the RVOT VTI. And then we moved forward and we assessed the filling pressures also by point-of-care ultrasound, and we used the point-of-care handheld device here, and it showed a SATS of 88% with an elevated E/E ratio of more than 2, and E/E prime estimated to be about 15, which brings an estimated pulmonary capillary wedge pressure of about 19 according to the NAGA formula. But it's not only about echocardiography. We also did lung ultrasound to try to understand and complement our echocardiographic study. We looked at the base of the lungs with the same probe, curvilinear probe. We saw big consolidation on the left screen here on your left-hand side with a degree of pleural effusion. And on your right-hand side, there was evidence of alveolar edema denoted by an abundant presence of B lines, making a coalescent pattern of elevated pulmonary water or extravascular lung water. So this patient was, according to the Intermax classification, in a class 1 shock, crash and burn, and this is the class of patients which requires a quick decision. In this context, our decision was to put the patient on peripheral VE ECMO. And according to the simulator, you will see in this pressure volume loop, as soon as the patient starts to develop acute heart failure, reduction of the stroke volume and increased in the cardiac pressures will bring the PV loop towards the right side. And also the size of the PV loop will be reduced due to the reduction of the stroke volume of the patient. And as soon as we instated the patient on peripheral VE ECMO, and this is an illustration which shows the configuration we used. So the peripheral VE ECMO is inserted via putting a drainage cannula into a big central vein. And in this patient, we put into the femoral vein, so draining blood from the right side of the heart. The drainage cannula is put into the IVC, and after returning this drained blood from the right side of the heart via the pump and then oxygenation, and then returning this oxygenated blood into the descending thoracic aorta. So you would expect, by bringing a constant non-pulsatile flow of blood with a peripheral VE ECMO into the descending thoracic aorta, that this will lead to a significant increase in LV end diastolic pressure. And this is what happens in the PV loop, and this is only for illustration, and this is not from the same patient. You will see that a significant shift of the PV loop into the right side as soon as the patient was put on peripheral VE ECMO. After a day or two, the patient was starting to develop worsening oxygenation and pulmonary congestion because of LV distension. And then the decision was made to put another modality of mechanical circulatory support, mainly to offload the left ventricle, because there were also signs of LV distension by echocardiography. And the modality we chose was the Impella CP, which is a trans-aortic axial flow pump, which sucks the blood via the inflow port from the left ventricle and return the blood through the outflow port, which is located in the ascending thoracic aorta above the aortic valve. And this is what we saw by the device, by the echocardiographic assessment at the bedside. The Impella device is located, the tip of the device is well into the LV. It might not be in the perfect position because the axis of the device is not well within the left ventricle, but there was no compromise of the mitral valve function and there was no significant mitral regurgitation. And then when we looked further with lung ultrasound, we also saw the presence of the lung water. And this is an example of the worsening degrees of lung aeration with lung ultrasound. At the top left, we saw normal aeration with A lines, and with worsening evolution of lung water, you will see none coalescent B lines and then coalescent B lines. And the worst degree of aeration at the bottom right of the screen is the presence of consolidation, which denotes complete deaeration of the lungs. But this patient provisionally was assumed to have had a sort of a septic cardiomyopathy. We didn't know exactly the cause of what he developed. He was too unwell to go to the cath lab, so we couldn't take him to the cath lab, but we couldn't see regional wall motion abnormality on admission, and the troponin was also mildly elevated, not significantly elevated, and there were no significant ECG changes when he arrived to us. But after 8 days of antimicrobial therapy and supportive therapy on the peripheral VE ECMO and the Impella, we started to see myocardial recovery. And this is an example of his echocardiogram after 8 days. The patient was successfully weaned from ECMO and the Impella after resolution of whatever cause, which led to the cardiogenic shock. And the VTI, as you can see here on the left side, is improved up to 19 centimeters. And when you also assess the right side of the heart and the lungs, you will see improvement in the pulmonary vascular resistance because it's not anymore acidotic. There is no reason to increase the pulmonary vascular resistance. And also the lungs has recovered. There is no evidence of lung edema with restoration of the normal aeration. But is it the end of the story? It's not the end of the story because there is another aspect of integrated point of care ultrasound, which is the aspect of assessing the systemic veins. And we looked at the systemic veins as soon as the patient was weaned from ECMO and mechanical support, because the patient was grossly edematous with worsening renal functions and reduced serum sodium levels, although he was extubated and breathing spontaneously on room air. So when we looked first into the IVC, it was quite dilated. It was more than 2.1 centimeters on the transhepatic window. And when we looked into the hepatic vein, and this is the trace in the middle, we saw a systolic reversal of the hepatic venous flow, which is an indicator of significant systemic venous congestion in the absence of significant tricuspid regurgitation. And this patient did not have tricuspid regurgitation after the heart recovered. And when we further looked into the portal vein to confirm the state of the volume status on the systemic venous side, you can see here the evidence of portal vein pulsatility on your right-hand side, which is a specific marker of significant systemic venous congestion. So what happened after that? We started to give the patient diuretics. Luckily, he did not require hemofiltration. And with diuresis, his hemodynamics were allowing us to diurese him. And then when we achieved 5 liters of negative fluid balance in the following few days, we started to see a significant improvement, reduction in the IVC diameter, restoration of IVC pulsatility, and also we started to see restoration of the normal tracing at the hepatic vein with the presence of the antegrade systolic and diastolic waveforms, and also resolution of the significant pulsatility, which we saw initially at the portal vein when he was significantly overloaded. So I will give a brief overview of what is the concept of systemic venous congestion assessment by ultrasound to try to explain how we put this in our integrated approach. So on the right-hand side, this is the very well-known and famous right atrial pressure waveform. We have the A and C and the V positive waves, and we have the X and Y negative deflections. And this is almost mirror-shaped to what we see usually at the hepatic venous waveform. We have 2 antegrade waves into the hepatic vein, one during systole and one during diastole. And we have only one retrograde wave, which is the A wave, which happens during atrial contraction. And how I do the protocol for assessing the hepatic and portal vein as part of systemic venous assessment, I do all the study from the transhepatic approach. I only tilt the probe to try to align my probe with the portal or hepatic vein. So once you put the probe into the transhepatic mid-axillary line, just below the diaphragm, you will see the liver on your right-hand side, and then you will see the hepatic vein appearing very thin-walled. You see the typical hepatic venous bifurcation, and once you see that, you apply color Doppler on the hepatic vein, and normally the flow in the hepatic vein appear blue-colored because it moves away from the transducer. And when you get this, you should put pulsed wave Doppler, and this is the tracing that you normally see. And once you see the tracing of the hepatic vein, you troubleshoot and you identify the abnormality of the volume status depending on the abnormality of the tracing. Normally, the S wave is bigger than the D, both of them antegrade. If the S wave becomes smaller than the D, this is an indicator of mildly abnormal systemic venous excess. And if the S wave is the only wave below the baseline, if the D wave is the only wave below the baseline and the S wave is completely reversed above the baseline, this is an indicator of systemic venous congestion at the severe degree. And what about the portal vein? From the same point of looking into the hepatic vein with the transhepatic approach, you only need to tilt the tail of the probe down. So you look with the probe up. And once you do that, you will start to see the portal vein, which appears brighter peripherally, so hyperechoic edges. And when you apply color Doppler on it, you see the normal typical flow by color, red in color, because it moves toward the transducer in the opposite direction of the hepatic vein. And the normal portal venous flow by color Doppler is non-pulsatile. And even by pulse wave Doppler, it should be monophasic and non-pulsatile. So seeing pulsatility either by color Doppler or by pulsed wave Doppler at the portal vein is an indicator for systemic venous congestion. And it is the most specific indicator that was identified so far. And those are examples of normal portal venous tracing. From the left-hand side to the right-hand side, you see an increase in the pulsatility, which is correlating very well with increased systemic venous fluid level. And the final part of the protocol for assessing the systemic veins is looking at the renal vessels, but it is the most difficult part of the protocol. And I don't routinely do it at the bedside because it can be time consuming. And especially in critically ill patients, it might be tricky to find with accuracy the renal vessels. And it can be also tricky to identify the renal vessels by color Doppler using handheld devices. But if you identify the renal vessels, you need to reduce the scale to try to bring it down to about 20 to 25, or even down to 10 to 25. And then this is the normal tracing that you see at the renal bundle, the renal vessels. Above the baseline is the normal tracing of the renal arterial flow, and below the baseline is the renal venous flow. And normally the renal venous flow is almost identical to the portal venous flow, and it should not be pulsatile in the context of normovolemia. And what's the importance of this protocol? We know for many years that portal vein and hepatic venous assessment and renal vascular assessment were part of fluid status assessment, but for the first time, the score for putting these together was validated a couple of years ago by a team in Montreal. They brought all this together and studied 145 patients after cardiac surgery. They did a repeated measurement every day for hepatic, portal, and renal vessels by color Doppler and pulsed wave Doppler, along with the IVC during the first 72 hours after cardiac surgery. And then they developed 5 prototypes of venous excess ultrasound. They called it VEXUS. And this VEXUS grading system brought to us those 4 grades of fluid status. Grade 0, normal IVC. So if you have a normal IVC, you don't need to assess for systemic venous fluid. But then if you have a dilated IVC, you can go forward and assess what I mentioned: hepatic vein, portal vein, and renal vein and artery. And then putting this together into the variable degrees of congestion, the normal, mildly abnormal, and severely abnormal, you can get a grade of VEXUS score, which can be used as a monitoring tool at the bedside for patient fluid status. But we should use these parameters, like any POCUS information, carefully. Only in the clinical context. Patients with pulmonary hypertension are adapted to high degrees of preload, so you should only offload very gently, even if the venous excess ultrasound score is very high, and it is often very high in these patients. And actually, in patients with right heart failure, the VEXUS score is a reflection of right heart function rather than the volume status. So we can use the VEXUS score in patients with right heart failure as a parameter to assess the improvement in right heart function with fluid removal, whether with diuresis or hemofiltration. And of course, if you see a patient with VEXUS 3 score, which is the fluid intolerance level, try to avoid to give any fluids to these patients unless they are strictly monitored. And we keep in mind that patients with VEXUS 3 score are also often diuretic resistant. So those are the patients, especially in the context of level 2 care or outpatient setting, those are the patients who require a combination of diuretics because they are often resistant to furosemide. And we should aim always for fluid tolerance and not fluid overload, avoiding the concept of fluid responsiveness. Because for many years, we have used the concept of fluid responsiveness to justify administrating IV fluids to patients without understanding what's happening on the dark side. And this is the dark side. And finally, we are able to look precisely with point-of-care ultrasound on what's happening on this dark side. And finally, if you see a tricuspid regurgitation, you should not rely only on hepatic venous flow. You should rely on portal vein, because these patients may have systolic reversal of hepatic venous flow without systemic venous excess, and portal venous flow will be specifically reliable in these patients. And this is an example of a protocol that we developed looking at cardiopulmonary ultrasound in 4 types of shock: in hypovolemic, in cardiogenic, in obstructive, and distributive shock. And by integrating cardiac and pulmonary ultrasound at the bedside, you will have better ability to identify the variable degrees and variable phenotypes of shock. And this is the integrated approach, not only heart and lung, but also VEXUS. So you're looking at the central veins, looking at the internal jugular vein, collapsibility, looking at the heart, looking at the lungs, parenchyma and pleura, looking at the portal vein, IVC, hepatic vein. And if you have time, look also at the renal vessels. You will have a better ability and more information to help you tailor the management required for your patient at the bedside. And finally, those are my take-home messages. Integrated POCUS, I believe, is useful in crashing patients and useful in cardiac critical care in general because it enables us to tailor the management to every single patient and not to provide the historical protocolized care to patients. POCUS is not a replacement for expert ultrasound. We are now witnessing advanced applications of point-of-care ultrasound, and you saw examples of tissue Doppler that were introduced recently on handheld devices, but this should not be an excuse for not to get the proper training and accreditation. And I think in the near future, there will be levels of POCUS accreditation, level 1, level 2, and level 3, which correlates to what we saw in cardiac ultrasound over the last years. And finally, and again, I'm reiterating the fact that training and accreditation is very important. POCUS is very useful and life-saving, but in the wrong hands, without training and proper learning, it can be dangerous, especially in the critically ill patients. And thank you very much for your attention.
Thank you. That was spectacular. Very, very useful. I was smiling all through it because you've taken my breath away. And you're so sweet. At the beginning, you mentioned the older cardiologists you used to work with in Egypt. But, to see you and Sarah and to see your very hard work earned meteoric rise, in my opinion, and to see how an older cardiologist like myself, who started cardiology before you probably went to medical school, is now learning from you. And from Sarah, from my younger colleagues, is for me, it's very, very satisfying. I'm so happy. I'm a little bit upset because I had just beginning to master what I learned from you about the B lines and the lung ultrasound, and I didn't find it very easy because I had to do it myself, looking at papers and videos, and now I have to go and do the portal veins and the hepatic veins. So I'm a little bit frustrated, but anyway, I'm quite happy. This was an amazing presentation. It really was. I don't know how to thank you, and I those are all my comments. I don't know if Alex wants to say anything or Sarah.
I echo Professor Henny's comments, and actually, Professor Henny, you were my professor. I mean, I've learned a lot from you, the basis of cardiology from you, and you've always driven me and forced me forward to learn more, achieve more, pursue more. So, I mean, I can't thank you enough. And for Hatem, that was an amazing lecture. I have to say, I've learned a lot from this lecture. As a multimodality imager, I have to say, and also as an adult congenital heart disease consultant, especially, I always find it tricky in assessing patients with RV failure. So I think I will take some of what you have taught me today in assessing my patients in the ITU. So I really appreciate that. So thank you.
Alex?
Yeah, so I mean, I don't have any comments on the case because, of course, I know the patient. But the comment, I suppose, the question that I do have, coming to on the last slide, Hatem, which is that you presented a phenomenally complex and intricate and masterly conducted ultrasonographic examination at multiple different points through this patient's journey. And I find it very hard to believe that in anyone's hands other than yours, the same information could possibly have been found. And I know that having shown me how to do VEXUS, I tried to do it the other day, and it wasn't as easy as when you were standing there showing me how to do it. So my question is, how do you move this forwards and democratize points of care clinical ultrasound to ensure that people are trained and credentialed to be able to make proper decisions, and to avoid people making the wrong decisions based on having inadequate skills to be able to do so? And how do you identify people to get to the standard that you are at? And should everyone be at that standard, or should there be one person in the department? Well, how should it be organized in terms of clinical applications, in terms of credentialing, and in terms of training?
This is a fantastic question, Alex. Before I answer,
before you answer Alex's question, yes. I'd like to add to it an extension to his question, because I also wanted to ask this question. Is there any dream of AI, artificial intelligence, giving us the Venus, the interpretation of the Venus waves of the portal vein and the hepatic vein? I mean, that's an extension of your question, Alex. I mean, you know, because we might not be able to train everybody, but AI might help those of us who have ultrasound skills, you know, but please start with the first part of his question. Thank you.
Absolutely. And actually, before starting the answer, I would like to say something. Maybe I've told Professor Raghi before. I think in the year 2005, 2006, I don't exactly remember the year, I attended Cardio Egypt for the first time in my life. And I was still in my early years of training as an intensivist. And I never forget how I admired the performance, the presentation, the skills of, especially, I do remember Professor Hani Raghi and Professor Ayman Abul Makt, and I have the honor of having both them on the panel. And I think this, you know, sometimes few incidents leave a stamp on you without feeling. And I'm sure this was one of the drives that I wanted to be a better physician. So I will just leave it there. And then I will answer your question, Alex. It's a fantastic question. It's a very tough journey, moving point of care ultrasound forward. But what has been achieved so far is great. And I think in the UK, we're very lucky to have the Intensive Care Society supporting fully the development of point of care ultrasound. The two chairs of the FUSIC committee in the UK are good friends of mine. And so far, they achieved tremendous work on moving forward with point of care ultrasound. Now we have accreditation in FUSIC in the heart module, accreditation in FUSIC lung, and accreditation in FUSIC abdominal assessment, which includes VEXUS. But the most difficult part is to try to bring accreditation into advanced levels, second and third degrees. But my thought is I was lucky because my journey started with echo. I learned echo from the best people in Egypt. And this was tremendously helpful for me when I tried to learn anything else in ultrasound. And I think for cardiologists who have good training in echocardiography, it is easy for them to learn the other aspects of ultrasound, because echocardiography is the most difficult aspect of all aspects of point of care ultrasound. If you master echocardiography, you can do anything. And that's my opinion. Might be wrong, but this is my own experience. But the journey is difficult, and there will be challenges. There are lots of politics around it, lots of friction sometimes. But I think this is the progress of point of care ultrasound is inevitable. No one will be able to stop it. It's now infiltrating all the specialties. We're seeing nephrologists, general physicians, many interdisciplinary interest into point of care ultrasound, not only at the basic level, but also at the advanced level. The point of Professor Raghi on AI is really important because some developers now are putting huge investments into artificial intelligence. And I'm aware of recent developments in artificial intelligence in handheld devices, which exactly looks at what Professor Raghi mentioned, looking at automatic analysis of waveforms by artificial intelligence. We have already auto VTI assessment by few of the vendors. We have automatic calculation of acceleration times, automatic calculation of E over E prime. And there are algorithms which are under study looking at the VEXUS, which I think will be very easy because other parameters have been implemented already. So this will help people get the learning quickly than what we wish. But I think expert echocardiographer still have the obligation to supervise and help pushing this forward. Because as an expert echocardiographer from the cardiology field, you have the ability to supervise, to mentor, and support, and make sure the learners are getting the best training. And I'm talking about all specialties. And those are my thoughts.
I have a quick question about the etiology in this case, because you mentioned it might be some kind of septic shock. Two quick questions. One, did we rule out myocarditis. I mean, even toxic myocarditis. The other one, I mean, the fact that the echoes looked okay and some biomarkers were okay, does that rule out? I might have missed it. Did the patient have a CMR to rule out myocarditis? And the other part is, if we're talking sepsis, did you put the level for the procalcitonin, or did I miss that? I would be interested to know what was the patient's procalcitonin.
Yeah, it was very high, and that was one of the strong reasons we suspected bacterial sepsis.
Okay.
Patient, and of course we didn't do cardiac MRI for this patient because he was too unwell, crashing and burning. But the other reason for also not thinking of myocarditis that the troponin level was not significantly elevated; it was only mildly elevated. So putting all this together made us think that it is possibly septic induced cardiac dysfunction. But yeah, unfortunately, we couldn't do any further investigations at that point.
I'm really amazed, Hatem, for your very elegant presentation of the case, and you opened the gates for the new modality of imaging in critical patients. And I think if we are not using such an expert imagers like you and Sarah and all of the expert imagers with also the advances in the technology and artificial intelligence to open the gates for helping the patient who are critical, as you mentioned, because the days before we are missing a lot of patients because of the way we diagnose them and the way we manage them among the diagnostic tools available at that time. But I think the way you give us to help the patient by imaging, to support the way of management, I think it is really great. And I'd like to thank you a lot for sharing with us, with Herfield Hospital, also team here. I'm very grateful for your support, Hatem, and I wish you always a great progress as you do.
Thank you, Professor Syed. That's a great honor again. Thank you very much for being all here with all my great friends. It's a great honor for me, and thank you for hosting us.
Thank you very much. Now I think we, after this really fantastic session, we can go now for the second session. But before we go, I'd like all of you to come up to the screen to take just a photo before we jump up to the second session. Professor Hani, can you join us, please? Professor Ayman, yes, we can now take one smiley photo here. Okay. Okay. It was really nice. We can jump now to Professor Ayman Abul Magd, Professor Heba, and Professor Hani to take the lead to present the coming session, please.
Thank you very much, Dr. Syed, for having us. It's always a pleasure being with you. I really enjoyed the last session. It was amazing. Dr. Hatem, Dr. Karim, and it was really amazing. We will welcome now. I will let Dr. Ayman please lead the way. Our professor, Dr. Ayman Abul Magd, please. Dr. Ayman, unmute.
Okay, thank you. First of all, I was thrilled and very excited to listen to the first session. The cases were just superb, really complex, different, and very educational, illustrative, and they highlight the complexities of medicine. We always say medicine is hard. It's hard because it has nothing to do with the books. We read in the books all kinds of things, and then you come and you face patients who didn't read the books, and they come to you with all sorts of strange reactions. We never see patients, like Hani said in the first case that Karim presented so eloquently. We never see patients with a normal creat of 0.8, and then they jump to 5.8 or whatever. Obviously, they don't read the books. They have other things. Why? Because they have baggage. When you're 82 years old, you're carrying so many things. And there's so many other things that we do that interact. Perhaps antibiotics that the patient was getting, that thousands of other people will be getting and will have no problem. But that certain patient, specific patient. The coupling of this antibiotic with the dye led to acute kidney injury. Possibly, I mean, I'm just throwing something out there, but I'm just trying to illustrate the complexities of patient management. Patients carry so much baggage when they come to you, especially the older they are, the more things, different things. And you have to add so many things together. That's why they always say, it's not just the numbers. You never treat just the numbers. It's really about the gestalt, the holistic, the totality of the situation of the patient. And that's what makes medicine always exciting, dynamic, and you never stop learning. Dr. Hatem Suleiman, I was just so impressed. It was an incredible presentation. I learned so much, too much. I need to read it again, listen to it again. I was just thrilled to listen to it. Every single slide, I learned something new, and it was just really exciting presentations. I don't want to take up too much of your time. Unfortunately, I don't have the program in my hand, but I believe Dr. Heba Ataya will be the next speaker.
No, Dr. I'm sharing with Dr. Reem Laimouna will be the next speaker.
Okay, Reem, Dr. Reem. Thank you very much, Heba, for enlightening me. And I'm really, I can't wait to hear Dr. Reem Laimouna presenting her presentation. Very exciting sessions.
Thank you so much. It's really my pleasure to be between you all, my dear professors and my dear colleagues. And thank you, Dr. Said, for the nice invitation. So I don't know if you can see my screen now.
Yes, we do.
Yeah, thank you. So it's about a case which turned to be more aggressive than expected. So let me start. Yeah. So she's a patient. She's a lady, a 90-year-old lady. She's a university student, recently moved from different country. She presented with recurrent palpitations since the age of 10. And actually, she was presented with repeated syncopal episodes in total loss of consciousness with no other specific medical history and no family history of sudden cardiac death or specific kind of arrhythmia. The Holter, the 24-hour Holter showed that sinus rhythm is the baseline. There was runs of supraventricular tachycardia and runs as well of non-sustained VTAC. As you can see here, this is the echo, transthoracic echocardiography, and you can appreciate that there is a degree of mitral valve prolapse, and a little bit anxious that Dr. Hani is here, so his area of specialty. So as you can see here, there is the preserved left ventricular systolic function, and this is the apical fourth chamber. A little bit upper normal size of the left ventricle and left atrium, but a preserved biventricular function. As you can appreciate, there is the mitral valve prolapse as well, in the little bit funny movement of the lateral ventricular wall. There was no significant mitral regurg, only mild. So now from the echocardiography, what do you think is the diagnosis? So first of all, it is mitral valve prolapse with mild mitral regurgitation, but the presentation of the patient with syncope in supraventricular tachycardia and non-sustained VTAC, that's why cardiac MRI was requested and the patient was referred to us. So this is the cardiac MRIs. You can see here, this is the fourth chamber cine views. Again, preserved biventricular systolic function and a little bit upper normal size of the left ventricle. And as you can see, again, the funny movement of the lateral wall in the mitral valve prolapse. As you can appreciate here, there is a gap. I don't know if you can spot it here. Just a second. Again, during systole, there is a gap between the left, the myocardium, the lateral wall of the myocardium and the base of the posterior mitral valve leaflet with a gap as shown here. Again, it's more clear there in the two-chamber view. Let me stop it. Yeah, and this is during systole. Again, there is a gap between the posterior mitral valve leaflet side of attachment to the left atrium and the start of the left ventricular myocardium, as you can see here. Again, with the strange movement of the lateral of the inferior wall, and you can appreciate here that there is a significant anterior mitral valve leaflet prolapse, and again with the posterior. And this distance was estimated as 11 to 12 millimeter in the 2-chamber view, but the 3-chamber view, it was 8 millimeters. And again, there's a confirmation that there is anterior mitral valve leaflet prolapse. So the late gadolinium enhancement for my colleagues who doesn't know much about the cardiac MRI, as you can appreciate, this is the normal myocardium usually in the late gadolinium enhancement appears as black, which is like this septum, which is healthy, normal myocardium, but actually in the lateral wall, as you can appreciate, there is an area of fibrosis, which is late gadolinium enhancement, which is white, a little bit whitish, different from the surrounding healthy myocardium. So it is supposed to be, we consider it as fibrosis, together with the papillary muscle as well shows some fibrosis. Again, with the short axis, this is the normal myocardium, which is black in color, and this is the whitish myocardium at the base of the anterolateral papillary muscle, the mid segment of the anterolateral wall, and partially this kind of fibrosis partially involves the anterolateral papillary muscle, and this is to correlate them both together. So now, after the cardiac MRI, we have a diagnosis of mitral annular disjunction with mitral valve prolapse, mild mitral regurgitation, papillary muscle and left ventricular lateral wall fibrosis associated with supraventricular tachycardia and non-sustained VTAC on Holter monitor. Again, if we go back to the echo, and if we look, look, as you can see here, just a second. Yeah. When we are in the systole, there is a gap between the posterior mitral valve leaflet, but I think there is a gap which is maybe overlooked during the first echocardiography, maybe is considered as a part of the mitral valve prolapse, but there is a gap between the start of the left ventricular myocardium and the base of the posterior mitral valve leaflet, which is attached here. So all of this is kind of a gap. And again, if we zoom, there is this gap creating this funny movement of the left ventricle. So regarding the mitral annular disjunction, it is calculated by the distance between the 2 points. The first is the site of attachment of the posterior or any mitral valve leaflet site of attachment to the left atrium and the start of the left ventricular myocardium. Usually, in the normal cases, there is no distance at all. This mitral valve leaflet should be attached at the base of the myocardium, left ventricular myocardium. Once there is a distance exceeding 1 millimeter, so we can diagnose it as mitral annular disjunction. In our case, it was 11 to 12 millimeters in the 2-chamber view. And this is, those are 2 cases. This is our case with mitral annular disjunction, and this is a case without mitral annular disjunction. So you can appreciate this is the site of insertion of the mitral valve, leaflet, posterior mitral valve leaflet, attached on the top of the myocardium. However, you can see here, you can appreciate the wide distance between two of them, creating some strange or abnormal movement of the ventricular myocardium. So when we went back to the literature to explore more about the mitral annular disjunction and if it is a serious disease or not, could it explain the arrhythmia that the patient is suffering from or not? But we didn't find. We found all the mitral annular disjunction is considered as part of the mitral valve prolapse, but actually there is a paper published in the JACC by Lars et al. In 2018 about the mitral annular disjunction and arrhythmogenic syndrome. Actually, they studied 122 patients with suspected mitral annular disjunction and confirmed once of them. There was confirmed 116 to have the disease. They used echocardiography, cardiac MRI, Holter monitoring together with the clinical presentation of the patient. And they diagnosed the mitral annular disjunction to be the distance again between the top of the ventricular myocardium and the base or the site of attachment of the mitral valve leaflet to the left atrium. And this distance, it exceeds 1 millimeter, so it is diagnosed to have mitral annular disjunction at any of the longitudinal axis. So they defined it anatomically to be abnormal atrial displacement of the mitral valve leaflet hinge point of 1 or more millimeter at the end systole. They have noticed as well that there is curly movement or curling movement of the basal lateral wall of the ventricles by visual assessment. They also documented that the mitral annular disjunction has previously described as a part of the mitral valve prolapse. However, in this study, they demonstrated that 22% of the patients, of the examined patients to have the mitral annular disjunction didn't have any mitral valve prolapse. There is another diagram from the another paper, a review article by Tani et al., published 2021. And this is, again, how do we measure the mitral annular disjunction by the distance between the top of the myocardial wall and the site of attachment of the mitral valve to the mitral valve leaflet to the left atrium during systole. Back to Lars et al., which is the paper with 122 patients. They correlated the mitral annular disjunction to be associated with arrhythmias, and 34% of the patients had ventricular arrhythmias, including ranging from non-sustained VTAC up to severe arrhythmogenic events, including sudden cardiac death. They found a clear association between severe arrhythmogenic events in mitral annular disjunction dependent from the mitral valve prolapse. And the study associated as well the presence of the late gadolinium enhancement or papillary muscle fibrosis in severe events. Maybe due to the potential, this kind of fibrosis may be a potential substrate for this ventricular arrhythmias. Therefore, they assume in their paper that the mitral annular disjunction itself may play an important role in the arrhythmogenesis. They found that the ventricular arrhythmias were more detected in patients with younger age, with patients with previous syncope, but this could be a little bit of bias in the patient selection, because patients who are referred for examination or referred for echo and cardiac MRI are most probably the patients presenting with symptoms, either syncope or ventricular arrhythmias. They saw the ventricular arrhythmias associated with large longitudinal distance, again, between the site of attachment of the mitral valve leaflet and the diastart of the myocardium. And they found it as well increased ventricular arrhythmias in the patients with fibrosis in the papillary muscle in late gadolinium enhancement MRI. So back to our patient, and the treatment of our patient was because there is no enough data about the disease itself, and hence the recommended treatment in the guidelines. It's not yet in the guidelines the uniform treatment. So our EP team decided to proceed for the ablation of the documented supraventricular tachycardia, which was AVNRT in the EP study, and they already ablated the patient. But the question now is, what about the non-sustained ventricular tachycardia, and is it responsible for any of the syncopal episodes that the patient suffered from? So they decided to implant the loop recorder to detect the burden of the non-sustained ventricular tachycardia, and if there is any ventricular episodes that is related to any syncopal or any syncopal episodes or any presentation, and then to decide either to implant an ICD or not. So again, we need wider scale research is required to answer many questions. Does it have any genetic element? Is a mitral annular disjunction arrhythmogenic syndrome by itself, or the papillary muscle fibrosis or the myocardial fibrosis is the main substrate for the ventricular arrhythmias in either of the diseases, in either the mitral valve prolapse or the mitral annular disjunction? I mean, if it is equal in both diseases, or even the fibrosis or the fibrous tissue between the start of the myocardium and the hinge point of the mitral valve annulus is responsible for those arrhythmias. So we need more research to answer this. And or if the arrhythmia is, or if the continuous systolic mechanical stretch on the myocardium closer to the papillary muscle due to mitral valve, either of the disease, the prolapse or the annular disjunction, is responsible for the progression in the long-term fibrosis of the papillary muscle and the left ventricular wall, and then responsible for the arrhythmia as well. So actually, we need more research to answer all of those questions. But my take-home messages from this case is the mitral annular disjunction is defined as anatomically is the atrial displacement of the mitral valve leaflet hinge point of 1 or more millimeter at the in systole at any of the longitudinal axis. Mitral valve prolapse could be associated with mitral annular disjunction. However, it's not essential for the diagnosis, and the disjunction can occur alone. papillary muscle or left ventricular myocardial fibrosis is detected in mitral annular disjunction. The annular disjunction itself could be, without the mitral valve prolapse, could be a risk factor for serious arrhythmogenic events. Definitely, echocardiography is the first modality to diagnose the condition because of the availability, the first referral, the cost effectiveness. So echocardiography is the first modality. However, cardiac MRI is considered now, with the limited data, is the modality of choice for the accurate assessment of the extent of this displacement due to the higher spatial resolution to measure the accurate distance. And the second place is, the second issue is the detection of the myocardial fibrosis by late gadolinium enhancement, which is believed till now is the substrate for the ventricular arrhythmias. So limited data currently suggests the existence of a new disease or a new syndrome. It's called mitral annular disjunction arrhythmogenic syndrome, but still, as we said, it is still under research and need more and more cases and more follow-up and long-term follow-up to examine for the to answer the question, all the questions, and to determine the prognosis, and hence to decide the treatment and the follow-up plans. Thank you.
All right, thank you so much. This was, again, very enlightening. And I think it's enlightening because, to me, it provides an answer to this marked discrepancy between what we read in our textbooks about mitral valve collapse and what we saw in practice, and how much of a discrepancy there is in the literature regarding the potential for mitral valve collapse to cause syncope and so many problems in patients. And what we usually see, what all of us see, all of us all over the world, of seeing so many cases of benign mitral valve collapse that do nothing. And yet the textbooks have always said there's cases with mitral valve collapse that have syncope or sudden death. It's a rare occurrence, but it happens. But we never knew which patients were liable to have problems, and whereas we see overwhelming majority not having problems. Obviously, I think, to me, what I learned when I picked up from your presentation is that this provides a potential explanation for this discrepancy, that probably the patients that were seen before, perhaps due to the evolution of better resolution of the echo machines now, were more capable of discerning and seeing this gap that perhaps wasn't seen in 10, 15, 20, 30 years ago. So now with better machines, we're able to see more, we're able to correlate more, and it provides a very possible explanation and selection for which patients with mitral valve prolapse, what we're now calling MAD, as being high risk for events. Because what most of us have seen, we'd see people with mitral valve prolapse and we say, oh, they have palpitations, and you do a Holter, 48 hours, 72 hours, nothing happens, and you tell them, you just reassure them. But obviously some of them have problems. Now the issue is, where's the problem coming from? Is it from the gap, or is it? And if they're born with it, you showed some correlations. More likely to have problems in the younger age group. Maybe they have more severe, and you also mentioned they have a longer gap, a bigger gap. It had to be at least 1 millimeter. You should see no gap. You had at least 1 millimeter. The definition was at least 1 millimeter. And you had some with 10, 15. And the longer the gap, the more likely they were to have arrhythmias. Is that correct?
To be honest, it was not that clear. There is a suspicion that that the gap is related to more arrhythmias and more significant disease. But we need larger scale studies, because this study, for example, yes, they said that it is correlated, but they had only 116 patients. So we need larger scale to correlate the longer term.
Yes, I think we're just beginning to explore this area. Exactly. And perhaps it's the continuous abnormality of the ventricular contractility leading to the fibrosis, which that you showed elegantly by MRI, and ultimately this leads to an arrhythmogenic substrate where possibly there was none before. I would have liked to. You said there was one sentence that I was hoping you had, the cardiology literature had more data about, which is that there was a higher possibility, there was a higher incidence of arrhythmias in those with more fibrosis. Is that correct?
Yes, exactly.
Okay, what was the percentage of those who had fibrosis? How many had the arrhythmias?
In this paper, there was 34% have serious arrhythmias. With this
of those with fibrosis?
With those, with all of the patients with serious arrhythmias have left ventricular fibrosis. But to be honest, again, it is a very little amount. In the, for the other diseases or other cardiomyopathies, some papers were talking about the percentage of the myocardium which is fibrosed, ranging from 5 to 8% to cause serious ventricular arrhythmias. But again, more research is needed. So we don't know how percentage of the myocardium should be fibrosed to cause this kind of arrhythmia. Is it just a focal arrhythmia that can cause this? Is it this, like, how many millimeters, how many segments is the upper limit? But it's still not there in the literature.
Well, we have to start, at least after all these years, we found something that is definitely worth investigating and pursuing.
Yeah, the issue is what I can. Why is the delay? Because maybe the cardiac MRI is recently introduced to this kind of disease. So usually mitral valve prolapse will not refer for cardiac MRI to detect if there is any kind of fibrosis or not. But when it is now widely used, and you can refer your patients with syncope or cardiac arrest or whatever to the cardiac MRI, so we can detect more and more fibrosis and more substrate to explain why the disease was there in the first place.
Very interesting, very interesting. Thank you. Now I'd love to hear Dr. Hani Mahmoud's perspective, another expert in the field. I love your presentations and your hand explanations.
I was very anxious when I knew
they were brilliant. They were brilliant. I have to tell you.
Yeah, I was sitting doing nothing at my office, just doing like that.
So you came up with some brilliant stuff.
Yeah. Thanks a lot. Thank you so much, Reem. That was really amazing. I like the presentation. I like the images, both from echo and MRI perspectives were very nice and clear, crystal clear for me. I will just need to, for the audience, from like a learning perspective for them, would you advocate doing CMR in patients with mitral endless disjunction based on echocardiography with or without arrhythmias, or you'll just limit the MRI request for those? Because the aim of these webinars are educational. So people now listening to you, if they got a patient with or without arrhythmia or without syncope, with a clear MAD, would you advocate referring them for CMR or not? After that, I have a comment to expand a little bit on some comments that Professor Raymond said.
Okay, theoretically on the real life, theoretically. Actually, in the real life, it is costly. Cardiac MRI is not a thing. Even if it is, in the NHS here, which is free for the patient, but actually it costs the system. So I think it is a little bit costly. So according to the clinical presentation of the patient, if there is something serious, we need to investigate. But usually, all the patients that I've seen in 2 years of practice of cardiac MRI, I've seen just 4 patients, and all of them with serious arrhythmias and syncope, true syncope, and one of them was aborted cardiac arrest. So to be honest, in my experience, yes, I will refer patients for cardiac MRI to investigate more to see if there is this kind of fibrosis and how is the extent of the fibrosis. Do we need a further step for follow-up on ICD implantation or not? But yes, I will say yes. But according to the cost and according to the presentation, it is a little bit limited and still under research. That's why we need wider scale, not taking the cost in consideration with larger number of patients to be fair and to put the guidelines. Like for example, the ARVC was not diagnosed years and years ago, but now we have criteria, ECG criteria, clinical criteria, and cardiac MRI. So I think on the longer term, yes, we may have this kind of guidelines and the pattern to diagnose the disease.
Yeah, thank you so much for that.
If you'd allow me, Dr. Hani, Dr. Hani and Dr. Reem, it's rather, and an answer to Dr. Ayman, it's not actually only the amount of fibrosis, it's also the location of this fibrosis. Because even the smallest amount of fibrosis that might introduce a reentrant circuit that will exacerbate the tiniest focus possible. So I think the research would be rather guided into or located or more targeting not only the presence and the degree of fibrosis, but also the location of this fibrosis and its relation to the mitral annular dysfunction, disjunction, because I think it might be a disease entity different than the mitral valve prolapse by itself. It might be even present. We found this in the mitral valve prolapse, but we might, if we look for it, we might find it elsewhere. I don't know whether Dr. Hani would agree on this or not.
Yeah. Thank you so much. That's a great point. I will just need to focus on 2 points, but for the sake of time, we don't need to encroach on the second speaker. But answering 2, or I'll just give 2 comments. One on the fibrosis. Fibrosis has been always famous for being a substrate for arrhythmias, but in this particular patient category, it might be just a coincidence. I don't want to say that it's not causing fibrosis. The traction, the continuous traction, the mechanical traction on this site arouses the LV definitely, and it may lead to fibrosis later on. So we don't know exactly what happened first. We see in the cath lab, once the big tail catheter or the wire goes inside the LV, arrhythmia starts immediately. So mechanical triggering of the LV can definitely cause arrhythmias. We see that every day in the cath lab at any hospital. So fibrosis at this particular point, for me, it might be easier to understand this because of the continuous traction, whether the mechanical traction caused both the arrhythmias and fibrosis, or one aggravated the other one. That needs to be elaborated on more and by further studies and research. Second thing, the distance of the MAD, the mitral annular disjunction. I have seen from some experts, they told me they have seen some patients that had an ICD with a MAD of 3 millimeters only, and the patient presented with VT and sudden cardiac death. So I think, again, that's a question for research. It needs larger scale studies in order to understand whether the distance of the MAD is really related to the arrhythmias or sudden cardiac death or not. But I'm happy, as Professor Ayman said, that's a new entity that became well recognized recently. So, and very interesting, and it might be life-saving in order to, if we saw something that really can treat this entity of patients. Thanks a lot, Reem.
Can't agree more. Thank you, Dr. Hani. So we'll move to the next speaker, Dr. Vasilios Panolis, consultant cardiology, honorary senior clinical lecturer, Imperial College of London. Please, Dr. Vasilios. Dr. Vasilis, you already shared the screen. Would you start, please, your
I
test?
can't hear you. Maybe you're unmuted.
Can you hear me, please?
Yes, I can hear. Can you hear me now better?
Yes, good.
Perfect. Thank you very much for inviting me to be part of this fantastic course and webinar. I will take you back to the more boring valve again, to the aortic stenosis. But I think there's a subject that we often encounter in our daily practice, a combination of coexisting coronary disease, critical aortic stenosis, and severe LV impairment, something that very often we are perplexed how to treat. So I have prepared a couple of slides to just show to people something that I think we all know now, this SCAI shock classification that starts with an A and ends with an E, recently updated by Dr. Naidu. And the reason why I show this is because I think there is a lot of cases, particularly those in SCAI A, as we call them, people that are not in shock but have the possibility to get into shock while we do some procedures on them. And I put together some things that I believe that contribute to the potential for instability. And these are, of course, relating to the LV and RV function. They relate to the complexity of the coronary anatomy. They relate to the presence of arrhythmias, as you were just discussing, and of course relates to the presence of concomitant valvular disease. All of these that are related to the heart, I put it as a cross, alongside the comorbidities that the patient can have. The first case that was presented today was severe acute kidney injury. But again, other patients have COPD, peripheral vascular disease, strokes, etc. So in Harefield, we have designed a protocol on how to treat patients that come to us in shock. We have a very big primary PCI program. Therefore, we need to act fast. But apart from the patients that are in the C, D, and E classification that we discuss and have a proper shock team that comes along and discusses whether we need impellers or ECMOs or both, there are these patients in SCAI A and B that some of them might need some mechanical circulatory support, particularly when they have very high-risk features. And again, what are these high-risk features? When you see a heart that's pumping like this, for example, and you see aortic stenosis presence, when you see the coronary anatomy that is relying on a last remaining conduit and it's a left main that looks like that, when you see an LV function that is not particularly appearing, particularly for you to do complex interventions in coronaries or indeed on the valves, when you see arrhythmias, all of the above. So without further ado, I'll just present 3 cases that I have performed with the help of my colleagues in Harefield. One of them, 80-year-old female line dancing teacher, so in a fantastic state, a very well-standing lady that presented to her local hospital with a decompensated heart failure and pulmonary edema. She had, of course, a small troponin rise to perplex things a bit. She was mainly troubled by breathlessness, but also a bit of angina before. She came with a left bundle on the ECG, but she was hemodynamically stable and she had a normal lactate. So in this pyramid of SCAI shock, you would probably place her in SCAI A as someone that, even though they are stable, they have the potential to deteriorate. And if I draw you the table of her comorbidities and heart issues, you can see here that her ejection fraction on the left side was not great. She had a complex left main LAD and circumflex, which I'm going to show it to you. She had the left bundle, severe yes, and the comorbidities seen over there. So if we start with the echo, this is her LV function. Again, you could argue part of it is because of the valve, part of it is because of the coronary heart disease. A difficult question to answer, who's responsible for this. Then we did also a CMR, and this was mainly to show, because from the local hospital we knew that there was a chronic occlusion of the right coronary artery, so it was a question as to whether we need to do anything for that or not. But as you can see here, the inferior wall was completely infarcted. There was a transmural infarct, so that made the decision easier as to not to do anything for that. And then you can see the angiograms. So extremely tight ostial circumflex lesion. There's a lesion in the left main itself, in the body of the left main, and very diffuse and tight disease extending all the way down from the proximal to mid LAD. She was deemed from the heart team very high-risk surgical candidate, and our surgeons just washed their hands off. And then it comes to us as to whether, what do we fix? Because we have someone with symptoms of both angina, breathlessness, presentation with pulmonary edema, and this very complex coronary disease alongside aortic stenosis. So we did a CT TAVI to look at her peripheral access. And what we did is we started with a balloon valvuloplasty to facilitate an impella. As you saw in the previous picture, we did a single access. So from the same leg, we put the impella and it fits alongside the impella to put up to a 7 French catheter. Here we just had the 6. And then we started working on the coronaries. I don't want to particularly tire you with the logistics of how to deal with the coronaries, but we used extensive shock waving with 2.5 balloons in the proximal and medial diagnostic circumflex, and 3 zeros in the left main. And while the balloons were up, I think what is remarkable is that she didn't have any significant hemodynamic instability. She was talking to us, and everyone in the room was very calm. There wasn't even an anesthetist present for that procedure. Now, the reason we opted also for support is because of the complexity of the coronaries. We didn't know whether we would have to use rotablation or indeed shockwave. And even shockwave, that is considered the easier option, you do have to keep that balloon up for at least 10 to 15 seconds. And if the left main is the last remaining conduit, then you might run into trouble while having that balloon inflated and then rely on the adrenaline to save you and get the life of the patient back. So yes, with the stability of having an impella in despite the aortic stenosis, we had very good flows and we had very good hemodynamics. So we did as good job as we can. We used our OCT, we used our shockwave, we used our impella. This is how the room looked. During the case, it was me, my fellow, and a physiologist in the corner. These are and the nurse, as you can see, chilling at the back, not really stressed about anything. So we had a decent result. Both with coronary angiogram and OCT. And then 3 months later, we brought her back to finish the job by performing the TAVI using an Edwards 26 valve via the contralateral femoral access. So we used Manta to seal both axes with a good result. So this lady essentially went home 2 days after her TAVI, and now it's been a year. She's line dancing again, and her LV has actually improved to 45%. In another case, even though a bit older, as you can see here, you might ask me, what are you doing treating all these old people? But actually, I think that's a new norm. We see very well-standing people in their 80s that deserve to have a very good quality of life. So this gentleman, even though 88, he was phenomenal. He didn't have any other comorbidities apart from being an ex-smoker. And he presented to his local hospital with chest pain and congestive heart failure. He was shown to have a poor ejection fraction. And again, he had a normal lactate and hemodynamically was beginning to be a little bit more unstable. You can see here that in the schematic presentation that I did before, his problems were a poor LV, critical left main, CTO of his RCA, and severe critical aortic stenosis, of course, being a 88 and having the comorbidities. And here you can see a LV function, the aortic stenosis. And here is the money shot where you had the very hazy, very tight left main and a chronic occlusion on the right. So I hope that you agree that this is a case where you're thinking already decalcification strategies, you're thinking potentially rotablation, you're thinking potentially some people might do laser, some people might like to try the shockwave. But whatever you do, you have to appreciate this is a last remaining conduit in someone with severe aortic stenosis and poor LV function. So again, using our heart team approach, we agreed that probably the safest option for this gentleman would be to provide him with some support. And so we did a BAV, we put the impella. Normally we do the BAVs with smaller balloons so we don't create torrential AR in the process. So BAV impella, and then we started tackling the left main. We used shockwave IBL balloons, biggest 3.5, delivered all the 80 pulses that we had to deliver, again, in a very stable scenario, not intubated or anything like that. Final result there, we used also average to make sure that we have a good, well-opposed result. And from the same axis that we did the impeller and PCI, because obviously we do it in one go, we removed the impeller and we left the 14 peel away French sheath. So we then put a stiff wire and we exchanged that for the Edwards E sheath. And then in essence, by using only one single axis, we performed the Edwards Sapien 329 valve to finish off the procedure essentially. And you can see here the final result. So it took us in total 1 hour and 40 minutes to do this left main PCI. So valve impeller, left main PCI, and TAVI. Again, the patient ended up with a very good result. His LV improved nearly quite imminently. Is one of those cases that the aortic stenosis was critical, and now he's doing well again. He's been a year out, and he's fantastic, and he leads a great life. And the third case that I think for me was a landmark in my career in terms of the amount of decision making we had to do, the amount of collaboration of the whole every team in Harefield. It was just a phenomenal case. We had a chap who came from his local hospital again with decompensated heart failure. He was in what we call a kind of classic cardiogenic shock, where you are stable but you're not inotrope. So he was relying on milrinone to move around. His lactate was kind of hovering around the 2 marks. So he's a C in this pyramid, and now I'm going to show you the issues that this gentleman had. So 62. He used to drink alcohol in excess. He was diabetic and ex-smoker. He came with us with an ejection fraction of, I quote 5%, but I think I'll show you the pictures and you tell me what you think. Very bad critical coronary disease with, again, the theme of the night, chronic occlusion of the RCA and very tight lesions in left main, LAD and SEC. And once again, severe bicuspid aortic stenosis. So this is his ventricle. I'm going to let this images play a bit, because I know with the internet sometimes there might be retardation. So I called it 5. I mean, you can call it 10, you can call it 2. I think bottom line is very poor ventricle. You can see here that's a bicuspid with the roughly there. You appreciate again in short axis that the left ventricle is barely moving. There's biventricular impairment, in fact. So again, the right ventricle is not. So this is a case of someone that potentially has a long-standing dilated cardiomyopathy with concomitant severe aortic stenosis and indeed coronary artery disease. So quite a tough situation to be in. And in fact, because of very high PVR, because of him being a recent smoker, up to recent drinker, he was not deemed fit for transplantation. So he didn't really have a way out of hospital other than us trying to fix the things that we can fix. And these were just the aortic valve and the coronaries. So you can see also we performed an MRI to that regard. You can see a very dilated right and indeed left ventricle with very, very poor systolic function indeed. And even the TAVI CT, the people in the TAVI scanner used the normal protocols, and the contrast, as you can see, didn't actually move the legs to opacify well the iliofemoral, so they had to repeat it again to slow down a bit the times, so allowing for the contrast to reach the target. So you can see that his iliofemorals were not that bad. There is some calcification, probably a bit more than what you would expect for a 60-year-old, but doable for big access from both legs. So there was a lot of decision making to be done. Again, the aortic stenosis that was bicuspid, did some measurements, and it would fit the big valves. We decided for this case to support it with VA ECMO, because I thought, even though as you saw the previous cases, we had used impeller for the coronaries and then removed the impeller and put the TAVI, I thought for this man, we would need support during the TAVI implantation. I wasn't really sure that he would ever come out of a rapid pacing, and I wanted to have the best outcome for the patient. So what we did is we went on peripheral VA ECMO through the left femoral vein and artery, And then we used the right groin and axis to perform our PCI and indeed the TAVI. So you can see here the coronaries. It doesn't show very clear in the first picture, but here you can see distal left main, critical osteo, circumflex. And then you'll see there is a nearly subtotal occlusion on the proximal to mid LAD, very diffuse disease all the way down. So I think it would be a bit mad for anyone to start treating this patient without support, because I think the slightest derangement of hemodynamics would probably lead to certain death. I know, again, it's an area where we don't have evidence. We had him on 2.5 liters of ECMO, so not full flow ECMO, obviously, because you don't want to increase the afterload of this knackered heart. We performed our PCI within a reasonable time and with IVOS guidance. We made sure our stents are well expanded, etc., etc. I don't want to tire you. And then, again, through the same axis, we performed the PCI, the right femoral. We did our TAVI. And then we had to use also with a good result. You can see here the venous cannula going up. And then we used one of the radials to ensure that we sealed our legs satisfactorily and we didn't have any bleeding points, because as you can imagine, normally I like to use the contralateral axis to make sure that the TAVIs have sealed well and I don't have any extravasation. But in this case, I had to go from the radials to make sure that either of those sides were fine. So we dealt with the TAVI access site and sealed with a MANTA device, but then we were left with a VA ECMO. And I know traditionally in the most centers, the surgeons are the ones that put them in and they do the cut down and suture the arteries. But in Harefield, we have now developed a technique to remove percutaneous ECMOs if placed within 5 to 7 days using the MANTA device. And I'll show you how we kind of thought of this. So I perforate the cannula with a Kimmel needle, and then I insert a normal J wire, and then that essentially keeps your access patent and also avoids the bleeding out, let's say, of the patient, because in the old days we used to kind of play with the clippers, but then we were losing a lot of blood. Whereas with this technique, with a needle, with a Kimmel needle and a J wire inside, you're able to remove the cannula. And then on the wire that you have left inside, put the 18 French MANTA device, which is, for whoever doesn't know it, like a very big plug device that people call it like the angiocycle. Not exactly the same. It has a bit of a different mechanism, but it's essentially like an external plug that sits on top of the artery and seals the plug. And by doing that, in essence, we managed to remove the 17 French arterial ECMO cannula using an 18 French MANTA with a good result. The vein, again, we remove with the Z stitch. And even though you can see this the next day, the echo, the LV doesn't look that particularly improved. By the eye of faith, you could argue that in the 4-chamber view, you can see some improvement in the LV function. But we also like to confirm that there is some improvement. The patient already had been feeling a lot better, but here you can see with global strain, pre and post TAVI measurements already have pinked up on the right side, which is the day after TAVI. Indeed, a week later, he had the CRTD, and 10 days later, he managed to go home. And we've seen him again now. It's been over a year and a half, and he's doing great. His LV obviously hasn't recovered to normal, but it's an acceptable 25 to 30%, and he's able to walk up to the hills to his local shop. And obviously, I'm showing this picture with his consent. I don't want to tell you more. A lot of these cases, we have published them as a case series in this publication for whoever is interested to learn more about them. And I'm very happy to take any questions. Thank you very much.
Okay.
Thank you, Dr. Vasilev. Thank you very much.
Thank you. That was another very exciting presentation and presented some 3 very high-risk cases. Obviously, the last one is different from the first 2, illustrating a lot of skill and experience in managing these very complex cases. I'm just going to group the first 2 cases together. I was very happy that you were in both cases, you started with dilating the aortic valve first, which I think is very important. When you have severe left main disease, proximal coronary left main proximal LED in circumflex, I think it's very important to open up the aortic stenosis first, because in patients with severe aortic stenosis, you have LVH, and you have the CFR, FFR, and IFR. You're working higher up. You've lost a lot of your reserve, and that will frequently normalize as soon as you relieve the aortic stenosis. So you're providing better flow, better physiological flow through these coronary arteries. And then you can start doing them more safely, I believe. So I think it's very helpful, and I think it's very important. It's a very important issue to relieve the aortic stenosis first, then work on the coronaries, which you so elegantly and eloquently demonstrated. The third case, wow, ejection fraction of 5. My poorest was like 9 or 10. This was dramatic. Obviously, you can't argue with success. You've done a fabulous job, and you've shown a lot of the proper use of the technology, of the various technological aids we have. I just want to ask you, ECMO will increase afterload on an ejection fraction of 5. How do you feel about that? I mean, were you concerned about ECMO with an ejection fraction of 5? That's a ventricle that's only 5%. Would you have not perhaps gone to unloading? Another thing is, I wanted to ask you, because obviously with 3 complex cases, I'm going to have a lot of questions, and the questions are going to get intermingled between the cases. But I was wondering, did you get right heart cath on these patients? Calculate cardiac power.
Yes. So yes, we had right heart cath in all of them. But to answer your question about the afterload, we were very concerned about the afterload, and that's why we were running the ECMO, let's say, on neutral. So we had it in 2 liters, just about.
Yes. I noticed that.
Yeah, just about running to run rather than create a massive afterload for the patient. The problem is, Impella is a fantastic machine to unload the ventricle and be more physiological, and in essence avoid exactly that problem. But you cannot have an Impella and put a TAV in. So that's a reason why for this particular case we opted for the ECMO. And I guess if things went worse, we could again have the option of putting an Impella in again immediately post TAVI, if we felt that he would need some recovery period. So the Impella was in the room and waiting to go, not open because it's rather expensive, but it was in the room and waiting to go. For right heart cath, indeed, for all these people, he was also relying on milrinone, remember, but despite that, his cardiac power was something around 0.55. So he was still struggling badly, this man. And he had no way out.
Sure.
The other thing I want to say about your first point about doing the BAV before the coronaries, I think it's very, very important. A lot of people ask me, can you put the Impella without doing the BAV? And a lot of people out there say, yeah, sure, you can put an Impella without doing the BAV. The profile of the Impella is smaller than the profile of the TAVIs. My answer to that is, indeed, the Impella profile is 0.13. So, we call aortic stenosis anything less than 1 centimeter square. So the Impella area is 0.13. So yes, in theory, it will cross the aortic valve, but people forget that the Impella is railroaded on a 0.018-inch wire that is floppy and tiny and has no push on it. So my answer to these people is, I always do BAV before I put an Impella, because you never know where it's going to get stuck in the aortic valve. And as you said, you allow the patient to breathe a little bit more, because even that little valve you did will improve the coronary flow. Then the impeller will top it up, so it will make it even better, and then you have a much safer profile to start your procedure. So I think that's a very, very important comment. And to your other comment, all these patients get the right heart cath because as we're also a transplant center, we want to know, what's their PVRs and stuff like that. Because if these patients, particularly this last one, had a PVR of around 5, 6, they're untransplantable at that stage. So they're not eligible. So because of that, because of his ex-smoker, he was declared as, no way. And I had other patients that had similarly very high PVRs, very low cardiac outputs with critical aortic stenosis that then needed MCS and TAVI. And you will be surprised how remarkable the improvement in the right heart cath is within days. I will never forget, we had another case that I have it on my presentation, but I like not to show because I will eat up too much time. A valve in a freestyle, and another man that was in the brink of death, and we managed to reverse his hemodynamics purely by the TAVI. So imagine a ventricle of, again, 5% on ECMO, salvage ECMO, but before that, being able to generate 3 meters per second. So for me, one key point to the audience is, if you have these very bad ventricles, but they're still able to generate some decent gradients, you have to think that there is potential in that heart. And by opening that valve, you will gain. So I think that's, for me, the most important point to get out there. So if you see ventricles of less than 10% that are able to generate about 50 millimeters of mercury, even more, then you know that this ventricle has potential and you will do a lot of good by implanting a valve.
Which raises the issue. What is the lowest number compatible with life? Because I mean, this is amazing. I mean, 5%. It just, I think, what basically to me, what it highlights is the marked complexity of the reserve of the human body. It's because the circulation is not just the heart. It is the heart and the skeletal muscles of the legs. I actually was going to ask you the seemingly unrelated question. Was this patient, I noticed the last slide, he's able to go back and walk up the 1 to 2 miles to his shop.
He has, ridiculous. He was cachectic. He had cardiac cachexia when he came in. You could also see it in his face, right? You saw how thin and cachectic.
Right. What I'm wondering, this gentleman has a shop and he walks uphill to the shop, correct?
Yeah.
That's his lifestyle.
Yeah.
He probably has strong leg muscles, quadriceps, calves, and that compensates to a certain extent for the overall competence of the circulation of blood in the body. Because we've all seen this. And when I always talk to my patients about the importance of exercise, I always give them the example of 2 patients. Both of them with an ejection fraction of 20. One of them coming in my office, they're dyspneic, they're just miserable. And no matter how many medicines you're giving them, they have severe shortness of breath, orthopneic, the whole story. And another patient walks into my office and he's in great shape, completely asymptomatic, fully functional, very active. And he's got an ejection fraction of 20. We've all seen these patients. And the one difference I've always found was that those who have a poor ejection fraction and are asymptomatic, they have good leg muscles, which are responsible for the other half of the circulation. Because 5%, I think this is an area that needs more investigation. I think this is key, that he was walking up 1 to 2 miles uphill. I think this helped him unknowingly.
Yeah, absolutely agree. The venous return is phenomenal. As you said, there's two sides to the circulation. We tend to ignore it as cardiologists. Yes. But that's a very, very good point. Very good point indeed.
Dr. Hiba, Dr. Hani, if you have any comments for the case before ending up this really wonderful, fabulous
I would like to thank Dr. Vasilis for those wonderful cases that enriched our knowledge in the subject of aortic stenosis and multiple coronary atherosclerosis. Dr. Hani, if you'd like to comment.
Yeah, thanks a lot. These were amazing cases. I'm an imaging guy, but I was really astonished by what you have shown. And I just need to underline again the last statement you have mentioned, that even if the LV is too poor, creating a velocity of like 3 meters per second or more through a stenotic aortic valve is a good indicator that this ventricle has a reserve. Thanks a lot.
Again, it was really a fantastic and fabulous night with a bunch of really elegant presenters and panelists. And I'd like first to thank my dear friend, Dr. Hatem, who gave us the chance to be joined in the CaseBox this night with the Harefield Hospitals with Dr. Vasilis and Dr. Alex. And also I'd like to thank our great panelists, Professor Hani Raghi, Professor Ayman Abul Magd, Professor Hiba, Professor Hani Mahmoud. And also I'd like to thank the fantastic speakers for this night, Dr. Karim Atta, Dr. Reem Laimouna, Dr. Hatem, and also, of course, Dr. Vasilis for his fantastic critical cases. It was really wonderful. It will be recorded and it will be uploaded to the YouTube channel. We have a YouTube channel for most of the audience who cannot pick up this fantastic night to watch it again. I'd like to thank you all, and I wish you the best of luck. Thank you.
Thank you. Enjoyed it very much.
Thank you very much.
Great to see everybody.